It is really a pleasure to introduce Professor Joskowicz. He was one of the very first authors that I read when I started my PhD back in 2015. And he's currently professor at the School of Computer Science and Engineering at the Hebrew University of Jerusalem in Israel. He's also the founder and director of the Computer-Aided Surgery and Medical Image Processing Laboratory. He's a fellow of IEEE and ASME, so the American Society of Mechanical Engineers. And moreover, he's a member of the board of directors and current president of the MICAI Society. And he has published more than 350 papers in renowned scientific journals and has over 7,000 publications. So please welcome Professor Joskowicz.
If I can get my slides. Thank you very much for the introduction. Thank you very much for your presence, both virtually and here. I have the great privilege of being here in presence, which is something I miss very much for a number of years. Where's the camera? Okay. Okay. The camera is there. Okay. Thank you. So I thank very much Professor Nasir Nawab and his team for this great work. So I would like to give you the engineering perspective. Professor Parat did an amazing job. I very much liked his talk. And
we're not seeing you yet.
Oh.
Don't forget to share video and audio.
Right. So, okay, now you can see me. Thank you very much.
I have to share the slides.
Go down, choose top tone, freigeben.
This one, yeah, but this
Tone.
The quick buttons.
Bottom left.
this one.
No, the other left.
Okay.
Okay.
There.
Done. Okay. No, you have.
But yeah, but now he doesn't see it.
No, bring the zoom, zoom window.
I'm seeing it now.
Okay. Not for us.
Yeah, but I need to
Yeah, but
see
he
it.
doesn't see
Yeah,
it.
you need to see it.
Sorry. So while we fix these technical issues, I hope you can still hear me. I'm going to give you some themes are going to be very much in line with what Professor Parat told us. But I'll give you also a bit more of an engineering perspective of what has happened in the field and what are the key issues from my point of view, of course. Let's see. So while we get this thing organized.
Push es da. Drüber schieben.
Du bist normalerweise war, das wäre jetzt kein Presenter hier mehr.
Warte mal, du musst das Präsenten machen.
Okay. Okay, thank you. Thank you very much. So I like to give you a bit of a historical perspective, but I'll bring also two very specific issues that are very close to my heart. And I want to emphasize them here because I think they would be useful to most of you who are developing systems here. So I'm going to call this field in general chaos. This is for historical reasons. Back in the 90s, we talked about computer-aided orthopedic surgery. I recognize that the term it might be somewhat obsolete, but I'll still use it because it brings together a set of things. So I'll very briefly talk about the history. We've already seen some of the technologies. I'll pick on some specific examples, but this is where I'm going to talk more, put most of the emphasis in my talk. It's about the evaluation and the clinical acceptance and impact. We heard already some very interesting comments by Professor Parat. I will complement them and maybe even disagree with some of them. And then, of course, I'll say a couple of words about augmented reality. The previous speakers had done already a great job. So I'm just going to focus on some of the aspects and give you some perspectives. if you want to read a little bit more about this is based in two papers, a paper that I wrote myself and one by Fred Picard, who's one of the experts in the field as well. So I'd like to divide this mostly into four main periods. First of all, we're already quite old. 30 years is quite a number of years. And this is really the first clinical specialty together with neurosurgery. So navigation and robotics have been around for a very long time. And I would divide this into four periods. This is, of course, my perspective. The first one was the exciting times of developing for the first time things that we didn't think about, understanding what surgery was all about. Remember, I'm giving you the perspective from the technical point of view. Going into the OR, seeing all these things happening was really great. And then around 2000, the introduction of the commercial systems, we all thought that this was gonna really become the standard of care very soon. And this happened throughout about 8 years. And some of you might be old enough to remember that there was a recession in 2008 and there were some economic challenges, and this really created a lot of challenges. And then the questions starting to appear. Why do we need these expensive systems? Are they really going to do something? There's no capital going around. So there was somewhat of a winter that we experienced, 6-7 years. And then after that, a very strong revival, as Professor Parat alluded to, robotics, especially in the US, who was a slow adopter of this type of technologies, or even a no adopter of navigation and robotics, suddenly you saw a great interest in those. And you see nowadays less hype, more studies and meta studies, and a very strong commercial interest. So this is a good time to be in this field. That's the good news about this. So I would say that from that creature that was created 30 years ago, chaos is still alive and kicking. And of course, this summer school is approved. Just for the fun of it, I'll show you some of the very old videos from the 90s. This was a RoboDoc that was alluded for, the first robot for orthopedic surgery. This is the hip surgery, the knee surgery. The graininess of the video is on purpose. This is what videos used to look like before most of you guys were born. And this is the punchline was this photograph, a manually broached implant seat and a robotic one. This is, of course, for cementless implants. So clearly the fit is much better in the robotic one. And if you have a better fit, you don't have the loosening. And it was expected that this will make a big difference. We talked about the navigation. One of the pioneers happened here in Switzerland, the Bernese system, but by Professor Lutz Nolte and his team. And you could see by now, very, very familiar tracking devices and different views of different parts of the surgery. And the first clinical studies that's starting to show some benefit, and all of them, you're going to notice, are going to have this issue about the accuracy, measured in millimeters or degrees. And this was how these systems were evaluated. If technically the system was able to achieve less than 1 millimeter, you had a great system. Okay, and we'll come back to that. This is our own system for trauma surgery. You see, looks clunky, but this is the things we were. Of course, we didn't properly think about hand-eye coordination. This is my colleague, Professor Moshayov and Professor Milgrom. This was not very good user interface or augmented reality, but nevertheless, it did produce some of that. This is what validation looked at in the 90s. We used ourselves to get some X-rays based on that. I'll come back to the validation as well. So what do we see today? It's visible, it's known. Orthopedic surgeons know what computer-aided surgery is, unlike many years ago. And of course, if you see this compared to the Da Vinci system, which is a robotic system used for laparoscopy, you can say that the adoption has been relatively slow. And this is why I don't call this a paradigm shift or disruptive technology, but rather a progressive technology. And there's nothing wrong with that. This is really the message of my talk. Not everything has to be disruptive, and we'll try to understand why I think this is a progressive technology and not disruptive. So what are the key questions when you talk about a disruptive technology? You have to know if that you have clearly known clinical benefits, because after all, this is the key issue. Then indications and counterindications. Is this technology for everybody or not for everybody? What is the cost benefit? Even though the adoption has been slow, is the change progressive? Is it monotonic? Is sufficiently monotonic? And maybe there has not been a paradigm change, and this is where I would differ from Professor Barat. Maybe we don't have a paradigm change yet. And what is the future? And of course, the role of this augmented reality and different type of displays in the adoption of chaos. This last issue, I think, is very important, and I think it is. Of course, like any interesting question, there are no simple answers. So it's a combination of these. If we just look at the different technologies, we have seen already sufficient examples of the main groups, the preoperative planning, the different types of navigation and robotics, the imaging, which is an important part of allowing this to happen, and the guides. These patient-specific guides are simple mechanical solutions, which usually orthopedic surgeons like a lot because they're very simple to use and intuitive. They, of course, have some drawbacks, but are very useful. In terms of augmented reality and visualization, I would say that up to recently, we have not seen, except for very notorious works from groups here and in Munich, not seen a lot of that coming along in orthopedic surgery, but this is about to change, and this is important because this might help a lot in the acceptance. And of course, the issue of the surgical workflow. There is a much better awareness nowadays of what is the surgical workflow and what aspects of it you can or cannot change. This is something we didn't really understand at the very beginning. And how can I not mention deep learning? What's the role of deep learning in orthopedics? Is it, I mean, we've seen great changes in other fields, certainly in computer vision, but what is the role of deep learning in computer-aided orthopedic surgery? And of course, I'll say something about that towards the end. So without going into the details, you've seen a number of pictures. We have the planning, the navigation, very cool devices. The navigation can be electromagnetic. You don't need to provide all the degrees of freedom. Here are different devices. You can also measure not just position and angle, but also different forces applied to the knee. And there have been a number of solutions. I on purpose don't put here names because this is a non-commercial talk. You might or might not recognize newer or older systems, but basically you see here the variety and diversity of the type of devices: small robots, large robots, handheld robots, semi-active robots, different types of guides, very, very ingenious solutions from an engineering point of view, beautiful, beautiful engineering solutions. If we look at the X-rays, a big change has been with the use of X-ray fluoroscopy. X-ray fluoroscopy is a key working force in orthopedics, and this machine allows you to optimize a number of views, get 3D cuts and CT-like images and so on. Really something which has made a big difference. It's still a technology which is not accessible to most hospitals, but it's there, okay? You can really do quite a number of things with this. And then, as I mentioned, the patient-specific guides, it's a very important development because it's a simple mechanical solution. which of course has some of its drawbacks. It dates back from 1992. Professor Rademacher in Germany invented those basically as way before the 3D printing was there. So the idea of let's use something simple and mechanical was already there. It became, of course, more relevant with the rise of 3D printing. And nowadays, 3D printing is something which is well established and certainly has an important role to play in our field. So to summarize the advantages, or what we expected to be the advantages, because I'm going to contrast this with how we're going to do the evaluation. So, of course, we want to improve all aspects of treatment and its outcomes. Remember, surgery or surgical treatment is like a chain. If you have one link which is weak, the chain is going to break there. So you need to work on all the four aspects of it, because you can be very precise and have poor planning, or you can have great planning, but you cannot execute it. So in the end, it's the chain. There's no way to look at this only from one point of view. So obviously, for surgical planning, the implant and surgical approach selection certainly has made a great difference. The measurements, measure is something great. You can do the measurements on the image. Certainly for rigid structures, this makes a big difference. In terms of the execution, the gold standard from an engineering point of view, as I said, is accuracy. And we'll come back to that very soon. Improve control, lower variability, and the real-time intraoperative 3D measurements. This is something that some surgeons really like and is extremely useful because it allows you to do something that you could not do before, or very, very hard to do with X-rays. So the one who measures is the one who can improve. So measuring is an important tool, not only for the executing surgeon, but also to see if what happened and how were things put. We spoke a little bit about minimal invasive techniques. Certainly there is a strong drive towards that, and we do need that. The more minimally invasive it becomes, the harder it is and the more technology it requires. Let's think about this simplistically. Minimal invasiveness is inversely proportional to the amount of technology that you would need to support and do this. Lot of emphasis to reduce exposure to intraop X-rays, a lot of works that have already done some difference. And one of the other golden standards was shorten surgery time. Well, this has very rarely happened. Usually surgery time gets longer, and this upsets the surgeons, the hospital, and everybody. So this is a big issue. I mean, in most cases, to be honest, our technology has not managed to shorten significantly surgery time, or even has made it worse. Let's now look at the outcomes. Reproducibility and outliers. Again, if you do an average and most of the patients are at the average, you don't feel where are the outliers. We already saw that the importance is on the margins, no doubt about that. Revisions is another issue in orthopedics. If things are not done properly, or you could not know that they would go wrong, if you decrease the number of revisions, that's an objective parameter that you've done a better job. Okay. Other advantages or the measures, training, surgery training is an area which is often talked about. Unfortunately, since there is not much money into training, it's not pursued in a very active way, but the potential is there. I'd like to think about chaos as a total quality control, the same way the Toyota total quality control was introduced in the 80s. I think this is one of the great advantages of technology because you can measure things. And the cost reduction, still not there, but it's not necessarily from the equipment. It has to do with the staff, the complications, and revisions. Very hard to quantify. Okay, and the longevity, but of course, implant longevity, you have to wait a long time. By the time you figure out that this increases longevity, the technology is not relevant anymore. So this is a big issue. The research tool is a great research tool. All these navigation, robotics, different measuring devices do help advance science and research. And this is important for us and to see what needs to be used. And of course, there are other aspects such as marketing and other things which I'm not going to refer to. So I'd like now to give you a little bit of meat into this presentation and talk about the evaluation, because we said that in the end, we're here to improve the outcomes. Okay, so let me then focus on two aspects of what is the evaluation. You have radiological evaluation from a clinical point of view and a technical point of view. From a clinical point of view, radiology, X-rays, you have the outcome as we saw in the surgery. Now, after the pedicle screws were placed, there is a control X-ray, which is a control image, which shows and documents that the pedicles are in the proper location. So obviously this is important. In most cases it's X-rays because it's available. Sometimes you have a post-op CT or MRI. So this is essential. These images are always there. And then you have the functional parameters, for example, different standard scores, different flexion, leg length, different parameters that were established by the clinical societies. For example, the Knee Society score, which measures different aspects of what is the function that you're trying to combat. Now, this is very problematic because some of these are semi-quantitative. They are subject to some amount of subjectivity and they're not universally adopted. And therefore, unlike the parameters we like to measure, accuracy, it's something we all engineers agree on. But what is the functional score? What is the proper functional score for knee replacement? It's not something which is under debate and progressing even in surgical circles, clinical circles. So obviously, functional is an issue, and I'll give you a very specific examples on knee replacement, how this is important. And then studies are very important. This is how medicine advances. The population size, the condition, whether it's multi-center and meta-studies. Right now, we have more and more of those, so we have a much better understanding than 10 or even 20 years ago of what is the clinical benefit of our technology. We're in a better shape right now. So I said the problem with this is that some of the parameters here are not agreed upon, they're not collected systematically, and therefore the evaluation, which is based on a very hard-nosed clinical point of view, is lacking the parameters that we engineers like to have. From a technical point of view, the gold standard is accuracy. We spoke about that. I showed you examples from the very early 90s. If you're accurate, you're going to do a good job. There's some sort of a dogma that accuracy means doing the things properly. Repeatability, of course, because this is a concept we both clinicians and technical people understand. And we have some of the clinical measures, for example, implant alignment, angulation, leg length. These are things that are clinical parameters, but we can measure them, okay? Unlike the knee scores, unlike the functional score. And then we're in solid ground, because this is something we can compare across and measure. And one key issue that I'm going to talk about is the issue of inaccuracy and uncertainty. These two concepts are very often mixed up, and I'll show you why this can lead to wrong conclusions. So what is the problem? You can have things that look on the radiograph perfectly fine. You can say the leg length is exactly the same in the two legs, and still the patient complains, or still it didn't achieve the goal. So what's the problem? That it's not necessarily the clinical target, okay? Surgeons know also very well that sometimes a perfectly aligned implant is still no guarantee that the patient is going to be satisfied with the surgery or that that was the proper thing to do. And this really has to do with this issue of uncertainty, which I'm going to talk about. So to make things a little bit more concrete, I want to speak about two examples. We already saw a knee surgery, so this is great. So this way I won't have to explain some of these concepts. And the other one has to do, so it's the clinical evaluation of knee surgery. And I want to do also the technical evaluation of bone tumor surgery. It's also considered part of orthopedics. So this is a meta study we did several years ago with Dr. Andrew Pearl from the Hospital for Special Surgery in New York. And it was at the time the largest comparative meta study. Very recently, there have been other published, which is excellent because it shows that there is a great interest in this issue of how do you evaluate the clinical benefit of this surgery. As with this common with these meta studies, you start with a large set of papers and then you do a selection. In the end, you end up with you sum the number of patients on the relevant papers, and you say, this is my, and the papers cover this, this population. So it's about 500,000 patients reported in all these papers of different national registries. And there were navigation studies, robotic studies, and the number of patients. So this is a solid evidence. And what we looked at is the papers that report both radiological and functional studies. Okay, so these are the two parameters I told you that are of importance to the clinicians. And we look both at short term, which is what happens right after surgery. But remember, for knee surgery, you also want to know what happens in the mid and long term. Okay, and of course, this requires patience. And what is the revision rates? Because as I told you before, the revision rates does provide a direct correlation on the success of the surgery. Higher revision rates in shorter times mean less successful surgeries. Here are the type of examples of surgical variables that you can measure and quantify. Lower leg alignment, soft tissue balancing. There is a way to measure the soft tissue balancing in terms of the forces applied to the different ligaments. Joint line maintenance. This is how the joint line of the knee appears. Component alignment, component size, component fixation. So those are surgical variables, but these are measurable parameters in terms of being able to quantify them. Sorry. Okay. And okay. So for these outcomes, what you see here is that you have, of course, the femoral component, the tibial component, and the and the functional outcome. No difference between the manual versus the assisted system. So you see here, this was lumped together, navigation and robotics on one side, and the other control was a conventional technique. And for both of them, the papers reported whether there was or was no difference. Okay, I won't bore you with the details. But the point of my example here is that you can quantify these parameters, and based on this, you can say the following. Robotics and navigation does improve coronal sagittal angles for the knee. They're nearly identical for the rotation. Rotation of the knee is one of the key parameters for the functionality of the knee. And very few of these papers, of these 140 papers, reported any functional outcome data. Okay, so again, you can be technically doing a good job, but what is the functionality? Is that helping? Okay, so, sorry. So of course, we also looked at the different periods. Okay, this graph shows in red those who are against, means that there was no improvement or even they performed worse. In favor means that there was some improvement of the technology. As you see, the answer changes depending whether you're evaluating 6 months, a year, or 2 years after, or even 4 years afterwards. And this was the difference. there was a difference on those who did report some of these functional outcomes. All the numbers you see there are the ways in which you reach the conclusion. But the point I left them there is that you see you can quantify it. Okay, those are numbers that have ranges and can be quantified. And this, we can say that the functional outcomes were somewhat better, both in the short and long term. As you see here in these graphs, these rectangles show that it's slightly biased towards in favor. Okay, how about the alignment and component position? Certainly the prosthesis alignment positioning was slightly better. Whether that led to a better functional outcome, that's a different story. If you look at soft tissue balancing, there was a definitely, you see here, this rectangle is much more to the right. There is a more significant, much better when you use the technology. So here's an example of, probably it's all about soft tissue balancing. We already heard this from Professor Parret. This is already a good enough reason to do this in this way. Okay, so to conclude this short example, what we see is the following. Both for total knee and unicompartmental knee replacement, there are multiple surgical variables, and you have to control of them. It's not one of the variables that's going to tell you this is better. We would have loved that to be the case. You fix the angle, you fix this is it. It's multi-parametric, okay? And the conclusion is that it does improve, the soft tissue balance, the mechanical alignment, and the imposition. So if you take these three targets together, then there is an improvement. If you choose one of them by itself, for example, implant positioning, it's not enough, okay? So you have to bundle them or find what is the bundle that makes the difference. What was already clear, and this is one of the big things, it does reduce the variability in general and in terms of risk in atypical cases. What is missing? We saw that there was no standardized way of how to report the results. Each paper reports something slightly different, so it becomes a nightmare to really compare apples and apples. So there is a new initiative in the Computer-Aided Orthopedic Surgery Society to be and develop some of these standards. It's like the ISO standards, a very difficult thing to do. And the conclusion of the paper is that it's too early to say. But wait a second, too early? We've been already working on this for 10 or 15 years, so how come it's still too early to say? Well, unfortunately, this is the case. Okay, the second example I want to give you, and this is going to talk about the technical part, is about precision and variability when we're talking about bone tumor surgery. This is work that was performed by Olivier Cartier in Belgium and Professor Jean-Yves Génie in Strasbourg. And, oops, sorry. Yes, I'm trigger happy today. Okay. Okay, this is the experiment. This is the surgical problem is the following. You have a bone, a tumor in the bone. You need to do a resection of part of the bone. And of course, you have a certain safety margin because you want to resect as much of the tumor or all of it as possible and a margin, but as little as possible from the bone because it obviously weakens the bone. When you cut pieces of the bone, you're going to weaken the bone. And this is, of course, not a good thing. So this is usually done either with a guide, a patient-specific guide, like you see here in blue, or it can be done with navigation with a saw. You have a saw that is navigated. The bone is a rigid structure. If you establish a good registration between them and you put a tracker, you can basically perform very good cuts. And to simplify things for this example, let's look at what is the safety zone. So you have a certain target. Let's say you want to choose a resection margin. It's either one single cut, a single plane, or a couple of planes. So you define what is the resection plane. It's usually done in planes. And you have to define what is the resection margin. And remember, I told you, the more bone you cut, the worse it is. Okay, so you have to, if you go too low, you leave some tumor. If you go too high, you might affect the vessels and different nerves and so on. Okay, so you have to establish a certain safety zone. Okay, and this is how this was done. This is a cadaver study with different ones. What you see here is the margins that I showed you. The one below is the tumor, too little, and the one above is too much. And the target was set to 10 millimeters, 1 centimeter. This is about long bones. It's important to say. We're talking about tumors in long bones. So this is what you see. There were 10 senior surgeons and 13 junior surgeons. And one tumor, you see here 4 bone cuts. You measure the accuracy of each one of the bone cuts and how far it was from the resection margin. And you say, you come out with a measure that 31% were out of tolerance, meaning outside of the safety zone. And so we measure these. These are the kinds of things we love. You do the same thing for navigation, and you find that only 4% outside the tolerance zone. And if you do with a patient-specific guide, this was only a 2% outside the tolerance zone. The difference between 4 and 2% is not very significant. These were cadavers, of course, so obviously this is not a significant difference, but you see the way the distribution is. So clearly you can say navigation is better, and the patient-specific guides, because of the standard deviation and the outliers, it's even better. So this is already something you can measure. Everybody's happy because technically you're able to define something which is clinically meaningful. So this is an example in which you can measure things without recurring to the functional score. Okay, how about the difference between junior and senior surgeons? Sorry. Okay, so let's remember, this graph shows you risk of intralesional resection. That means how much you go outside the margin. If you have no margin, the risk is almost 100%. The bigger the margin, the lower the risk, obviously. Okay, and then this is what happens with freehand senior and junior surgeons. You see that they're pretty close. Okay, the larger the margin, the lower the risk in the way that these curves show. This is how this was evaluated. This is the risk, and then the X-rays to do that. What happened with navigation and patient-specific guides? Well, first of all, the 2 of them performed better. This is what we saw. Okay, so if we choose, let's say, a margin of 3 millimeters, this is going to be 77% risk. Or if we choose to do this with navigation, it's 15%, or even with the patient-specific guide, 2%. So this is very significant. Okay, clearly, there is no way this is going to be a benefit. Now, what's the difference between the 2 of them? And you see here that the junior and the senior do have a difference. The junior now trails much more. Okay, and this is really what can be seen here. You see that when the safety zone is narrow, you have the surgical accuracy, means the experience of the surgeon, the technology, and whatever local difficulties they have. You see here that the difference between the experienced surgeon and the non-experienced surgeon is much wider when things are more delicate. Okay, so basically what this means is that the difference between the experienced and non-experienced surgeon gets reduced significantly once you use the technology. Okay, so this is a very good outcome, because this means that the less experienced surgeons, or those who have less of a volume, can do as good as the others for this task of tumor resection. Okay, so what is the take-home message of this part? I showed you an example in which it was difficult to relate the functional outcome to the technical parameters we could measure. And I showed you a second example in which it's very well defined, because we define what is the safety zone, and then we can measure all the other parameters, and we can very nicely quantify all the parameters that are necessary. Okay, and let's go now, as I promised you, what is the difference between accuracy and, and how it should be understood in orthopedics. Professor Paret already had this shooting example, so this is great. So let's think about this of target shooting. On purpose, I use this clunky computer from the 90s, but this is basically, think of doing target shooting with this guy. This guy has a tie also. So they're shooting at the, and the premise that all we've been working with, and it's implicit in all the papers, is that if you improve the accuracy, you're going to improve the short and long-term results of the surgery. This is sort of a basic premise of most of the papers that you have been there. But there is a little question here. What is the surgical target? I mean, if you know what the target is, that's great. But who defines what this target is? And what is a sufficient accuracy and acceptable risk level? That's the really interesting question. And this really has to do with the two key concepts of inaccuracy and uncertainty with respect to what is the ground truth. So let me show you this in a very graphic way. Let's say you're shooting at the target and you've defined your target and the zone. Let's say this is what you think is, or what is defined by some higher intelligence or something. This is the ground truth. We don't know what that ground truth is, but we can estimate what goes around. Now, let's say you have some way of shooting and there is certain inaccuracy in this instrument, right? You have the arch and the inaccuracy is the arch and the archer, and you're shooting there. And then, but this has only to do with the archer and the instrument. And what is the uncertainty? The uncertainty is where you don't really know what is the ground truth. So I know that I have to go to a certain street, but I don't know the number. It's between 100 and 200, or I don't even know the name of the street. So then I'm inaccurate. I'm uncertain because I cannot know. I don't have access to what is this ground truth. Now, how do they combine? And this is the ways things can combine. If you have a large inaccuracy, let's say, I don't know if the hotel is in Siefelstrasse, somewhere between 100 and 200. If you get a GPS that's very accurate to the centimeter, it's not going to help you get there. Why? Because the inaccuracy is smaller than the uncertainty. So improving the accuracy is not going to do anything for you, right? And plus, you're never wrong, because if you don't know where you want really to get, you get more or less there, and it's fine. If the varus valgus is plus minus 5 degrees, or you don't define it in a different way, then you're never going to be wrong. So the surgeon is going to say, get out of my OR. I don't need your toys because I'm always accurate. I'm never wrong because I set what this is. Okay. Let's look at the other scenario. The other way around. If the inaccuracy is larger than the uncertainty, if I have a GPS that gives me location to within 500 meters, then of course improving matters, because then I can tell whether I'm inside or not. This is where we'd love to be. Okay, some surgical scenarios definitely have this. This is the example I gave you with the bone tumor resection. If I improve the accuracy, I clearly improve the outcome. This is where we all want to be. But look at this other scenario, the third scenario. I have my uncertainty and I have a large inaccuracy, and we said that reducing the inaccuracy improve things. This is worth doing, right? Because inaccuracy is larger than that. But let's say you do that, and this is what you find. You reduce the accuracy, but now it's moving away. So what this means is that if you use a technology to do this, you're always very precisely going to be wrong. Now you put the wrong address in the ways, and it's going to basically lead you, you make a mistake of 2 letters, it's going to lead you 20 kilometers from here. So you cannot blame the ways, you have to blame the one who put the data in, okay? So basically, we've seen this happen. Once you introduce these tools to the OR, suddenly you start reducing the bias and the distribution, and you discover a bias. This happens, for example, in knee surgeries, in which you would see that surgeons would consistently put things in varus or valgus. Why do you know that? Because now you're measuring. So then you can say, wait, maybe the technique was wrong. So this is how you can always be precisely wrong. You start measuring, you reduce the inaccuracy, and then you discover a pattern. Okay, and this has happened quite often in robotic surgery. We have seen that, in fact, that the body sometimes, for certain things, is more compliant than what was originally thought. This is especially true for knee and hip prosthesis. So you're not going to improve anything because, in any case, the inaccuracy is not going to buy you more. So if you want to do a comparative study, you have the following. The ideal number, the ground truth, is not known, okay? Because we don't know what that ideal number, nobody knows that. So the surgeons choose a target, okay? The target is what you're gonna measure, and you're gonna compare the target with conventional surgery or with navigated surgery, okay? In this case, you have uncertainty, right? Because the ideal is not known, you have to choose some target. Some targets have a large amount of uncertainty and others have a small amount of uncertainty, and therefore you cannot know. However, once you've set the target, you can measure the inaccuracy, both of the manual and the navigated. Now, many studies ignore the uncertainty of the target. So they fix a target, it has to be within 1 millimeter. What is the uncertainty for that specific patient or that specific surgery? So a good comparative study must specifically talk about the uncertainty of the target and then measure the accuracy with respect. You see many papers that say, oh, robotics navigation is useless. Why do they say that? Because they define the target in a specific way. Or others say it's great. It depends on how the target was defined, not on the inaccuracy of the system. Okay, so this is what I call the three-way comparison. I'm going to speed up a little bit here so I can finish on time. We have the clinical acceptance. It was already mentioned that the penetration of this technology is low. 5% at the time we did this for knee surgery that we did this survey. I found a paper, a more recent paper, that says about 11% of knee reconstruction surgeries are completed with robotic assistance. So really you have mixed results. You ask some surgeons, they'll say it sometimes helps, sometimes it doesn't. Some surgeons swear by the technology and others swear at the technology, and we still see that. And this is related to what I told you about. This is the issue of uncertainty and inaccuracy, okay? And the cost-benefit relation is simply unclear. But I still believe that it's here to stay in the long run because we eventually are going to overcome these measurement issues. Acceptance and impact are complex and multifactorial, so nobody has the glass ball to know whether when this is going to become acceptance. It has to do with the patient experience and with the clinical outcome. Those things are important, but cost has to be factored in. If the cost is very high, no matter what the patient experience or the clinical outcome is, it's going to be small. If you have a great clinical outcome, but the patient experience is terrible, it's still not going to work. Remember, patient experience is about the functional outcome. After all, it's the patient's leg or the running afterwards. Okay, so, sorry. Okay, so certainly augmented reality has a role in here because it's going to become more and more relevant as surgeries convert from open to minimally invasive. We saw that the Da Vinci system is a good example of this happening. So obviously AR is here to stay. There's much more awareness of the surgical workflow, and now we understand how to go into that. And also we know that augmented reality has been a great success very recently in mechanical engineering, inspection and maintenance. These are used. So I don't see any reason why this would not happen in surgery. So, sorry, to finish, what are the perspectives? It's not a panacea. Don't believe anybody that tells you that this is always superior. This is not the case. I showed you why. Is the paradigm change? I don't see disruption. Maybe from a clinical point of view, Professor Paret said it was more disruptive. I honestly don't see, and I don't see why it should be disruptive. It's okay if it's progressive, as long as it's progressive in the right direction, of course. It's multifactorial. It's a complicated story. We have to understand the indications and counterindications and improve clinical science and surgical practice. This is very important because this is happening. The more you measure, the better you do. Just last slide. What happens with surgeon-less surgery? Just a provocative thought. We're now getting into cars, right? I don't know, when Nasir and I were born, this was crazy. I mean, cars are not going to drive themselves. Of course, we thought that 5 years ago, they told us, oh, the cars are going to drive themselves in 5 years, 5 to 10 years. It's proving more difficult than what it is. So you could very easily say, what about surgery? Are we going to have surgeon-less surgeries? So obviously, you want to do is to watch the road and navigate there. And when you're doing surgery, you watch the body and the images. The images are the maps, and the reality is the patient there. You need everything here, right? The vision, the touch, the brain, the tools, you need everything. You cannot drive without any one of these senses. So if we compare, say, okay, if driverless cars are going to happen, what would it take for surgery to happen? Well, look at the numbers, and you'll very clearly and easily come to the same conclusion. There are billions of trips per day. There are not billions of surgeries per day. There are billions of users per day. There are not billions of expert users per day. This is a structural engineer environment, and anatomy and pathology is less structured than we'd like to think. Driving has simpler and fewer rules. Surgery requires much more complex, and there are much more standardized platforms for driving. We can standardize them, and surgery still does not have much standardization. You can acquire skills of driving in months, but surgery requires years of training. So the limited interactions, you're in your car and everything happens outside, and here the interactions are complex. So what do you think? Are we going to have soon surgeon-less surgeries? Obviously not. It's at least one order of magnitude. Those who know how to do the math will add a couple of more orders of magnitude. This is not going to happen, okay? The evolution will be different, and there are few commonalities, okay? I will skip this in the interest of time. There are ways. You do not do immediately autonomous drivings. There are steps on the way. You have maps, you have warning aids, you have driving functions, and in surgery, we can do the same thing. Anatomy modeling is our maps. Intraoperative imaging is our vision. Surgical navigation, okay? But this has been ongoing for 30 years. Those who remember the first CMU projects or the driving cars, but the surgery, we've only been going 25 years. But look at the investment. The investment curve is nowhere near and will never be anywhere near what you have for cars. So don't expect the surgeon-less surgeries to come quickly. Let me just skip this. And the question really is the following: is surgery going to be very different in 20 years from now? It will take much longer and be uneven across different procedures. It will evolve differently than the driverless cars, and it will be fraught with many false starts and failures. That's the way things evolve here, and it will require more than a few disruptive technologies. I mean, with all due respect, AR is not going to make the revolution in the field. It's going to help a lot, but it's not the only one who's going to do that. And the same thing for navigation and robotics. So it's going to be more incremental and less disruptive. and we're going to have to live with that. Okay, but it is here to stay. So thank you for your attention.
Thank you very much for this very interesting talk. And I think we had already a question in the chat. I will try to find it here. So on the skill versus technology slide, the difference seems to be more with technology, where you mentioned that it reduces the gap. Could you please briefly discuss that slide again?
The slide of the gap.
Yeah, between the skill versus technology.
Okay. Okay, here we go. I think this is the slide, I believe. Okay, see what is this one and the next one. You see here the conventional freehand, the gap between the junior and the senior. If you take any millimeter, 0, 1, 2, 3, you see that the gap stays more or less constant. And the gap between here is more significant. The senior and the junior, if you take the vertical line, you can see here that the distance there is at least twice. Okay, and this is shown briefly here. This is how you see that, you see the interval gets smaller. This is how the gap goes lower.
And there is another question in the chat.
Sure.
Could you please tell us about the learning curve and its effect on chaos? Within these studies, have you also evaluated the improvement of surgeons in doing chaos as they get trained with it?
Right. So if I understand, the question has to do, this is a very good question of how has the technology impacted surgeons and changed the way they do, they learn, etc. No doubt. This issue about being very precisely wrong, I've seen that happen. Surgeons that start measuring and start doing things realize that they have been doing things before they were able to measure in a way in which they averaged out. And once they have now the technology, they discover things, or they can do better things, or they can improve their surgical technique. It has also been reported that surgeons that use navigation for a while and then stopped using it, especially the young ones, do better than those who never use the navigation. So there are studies that definitely report that even if you don't use the technology afterwards, in some cases, your surgical skills have improved.
Yeah, that was also mentioned by Professor Parat that with the
Absolutely.
robots, when he
I can
doesn't use it.
testify that I've seen that happen with a number of surgeons, yes.
So are there any more questions? Maybe here from the audience? That one, I think that one was the one he just. What do you want to further add to the question?
Is there any study with the temporal improvement
Of the surgeon? So
of using cows?
yes. So the question is there any reported a journal paper or a report that surgeons have improved their performance after using cows technology?
For example, for 6 months, a year, 2 years, 5 years?
Oh, in what period of time?
I didn't mean, after using or before. Very often, our problem in the AR is that we compare with AR and without.
That's right.
But we don't compare a surgeon who has done 5 years AR
Exactly.
with a surgeon who has not done AR.
Right.
So has been any evaluation of someone who has done 15 years of navigated surgery versus someone who has done 15 years of without surgery, not someone who did 6 months without navigation, with navigation, versus someone who has done the traditional one. Has there been such a?
There have been some reported. I don't recall the paper offhand, but there are a number of papers. But it has been. I have observed it in the hospital where I work with the surgeons there. That at a certain point they stop. They force all the residents to train with the navigation system, and some of them don't use them, and afterwards they do whatever they want. But all of them report that there was an improvement in the time in which they use, even if they use it for 6 months or a year, it improves the spatial perception, the relationship with the X-rays. This was for trauma surgery, for example. There were a number of things that there was definitely, and the head of the department basically decided that he's going to put through all the residents through training with these tools, even if it's not used afterwards. And so the belief is because of that. I'll find you the papers. There are a few papers that do report something like that. Not many. Mm-hmm.
If there is no more questions, if there's other questions, about 20 years ago, maybe more, I was on a panel of NFS to evaluate the ERC, and then there was experiment they did with Trimmer, the steady hand-eye robot, and they had studied 20 surgeons, mm-hmm. and 18 of them improved their performance, and for 2 of them the performance was reduced. So statistically everybody was happy, but the 2 were the best in the world. The 2 that had decreased their performance were the best. Now, there was a question posed at that time to the committee. The choice between improving the average versus never having those best, because they would never feel the experience of their hand compensating, using that tremor for improving their surgery, because they were able to use that little tremor into their system to improve their surgery and be the best. So this was when Dr. also Farshad, when he was showing us his surgery, he was telling he has to show the backup. Now, all this, what do you think? What do you think about this balance between, or how should we go towards that? How would we?
I would say you don't have to choose. I mean, the 2 things are important. For a very experienced surgeon, the worst thing you can do with a new technology is to bring it to the most experienced surgeon, because that surgeon could probably do a great job without your technology. So if it's not part of the team, they're going to be extremely skeptical because it's not going to help them. But that's not the point. I mean, if it doesn't help them, what about the others? And this is like learning. In learning, not everybody learns in the same way. So the statistics point to the fact that, yes, for part of the lower curve, and especially those of the low volumes, are important. In trauma is also very much the case, because each case can be quite different from the other. So if you're shortening the learning curve and helping those, and even as I reported, you train them, they use the technology, and then afterwards they become good enough so that they don't need the technology, you've done something useful. And this is the way I would like to see this, not something that is always used. This is why I said there's not only indications and counterindications for patients, but also for surgeon use. I mean, why are you going to bring the navigation or like we saw in the surgery here, he doesn't need to take X-ray images. So he's sufficiently comfortable with that. He doesn't. Somebody else would have taken more X-ray images.
Thanks a lot, Leo, for a great talk. I just wanted to, in defense of AR, augmented reality. I think for me it's important that the surgeon be able to take over and
No
to
doubt.
be
Like the
able
driverless
to
cars, the same
and
thing.
take over, also bring dynamic innovation and variation into the system. Otherwise, we will block them from, if I can't change things, then it would be, and for them to change it, they have to see how the system is thinking and do dynamic, dynamic physiology and reaction of the body, so they could decide, am I going to take over or not? So and this is only in defense of AR. I think AR, for me, AR is really important because that would allow a control and observation of the expert, even if at some point some parts are automatic. Still, they can with AR, they can see what the system is thinking, what sensing the system is feeling, what circulation, or in the case we saw today, fluid, and also blood and etc. If the system make a decision, they would know what is behind this decision, and then they could interfere. So this was just in defense of AR.
Right. No, I'm not against. I mean, there's no doubt that there is a need for taking over. Just like in the driverless cars, you need to take over also that. And there's always the risk of, when you remember, we learned how to drive with a manual shift, and now suddenly there are almost none of those. And now many people don't know how to drive a manual shift. Okay. So whether you need to scale back, and then people now are using the Tesla and maybe their driving skill, this is extremely relevant. And I certainly believe that AR and the measuring, the fact that you measure things and display those measures and then let the surgeon decide whether to do that or not is the key. So it's always the surgeon in the loop. That's why it's provocative on purpose. I don't really believe in surgeon-less surgery. This is the...
Hello, thanks for this great talk. I have a question. You mentioned this initiative for standardization of measurements and probably consolidation between computer measurements and functional measurements. Can you tell us a bit how it is about and the strategy, what you plan to do?
Yes, because I'm certainly not the only one, nor the first one, to recognize that we have here a problem in terms of the measures, because something which is an axiom is that if you can measure, you can improve. You cannot improve what you cannot measure. I mean, this is something we believe in, also the surgeons, whether it be functional or technical or both, of course. So, and we saw after we did that meta study, I'm sure other authors of meta studies came to the same conclusion. It's very, I mean, some report this is very partial. There is no standard. So it becomes very hard to compare apples and apples. So there was this initiative, and the case, you need a society or a body, just like clinical societies set up standards, procedures, and things like that. We would need the same thing from a technical point of view, okay? Except that we need a bigger workforce and the involvement of industry to help us do that. It's like setting an ISO standard. It's very hard. It's time-consuming, it's laborious, and might even become quite boring. And you need money to support that. So within the Chaos Society, we cannot do that, but we need more industry involvement. We're trying to work on that because some of the financing for that should come from there and would be of benefit to everybody. But this is work in progress.
And have you also talking with surgeons about that? Are they willing to provide this data?
Again, they say, you know what, you do it and we'll be happy to use it. We have created panels and discussions, and they have contributed. We have some initial material, but yes, it's going to be slow, but it is needed. Everybody agrees that we need it.
Thanks.
Okay.
So I have a question for you and also for Professor Nawab, now that I have you both here. You mentioned, both of you were discussing now, like the ethical kind of side of the augmented reality, of how far we can go with them. Where should we draw the line in which technology should be implemented in the OR? in terms of skills needed. Because, for example, if we develop so complex technologies that we are able to do operations that we were not able to do before, but if the surgeon cannot operate without those kind of technologies, and then there is like no fallback plan,
Right.
How do we design technologies so that we are able also to draw the line in what we shouldn't do in the OR?
Right. This is a very good question, because in fact, if I go back to this slide of what is the value, this was the value to the patient or to the company, there's value to the clinician as well. And this has to be factored in this simplistic equation. In other words, you could think of something like this. I mean, you always divide by cost, because this is what happens, but it would be a nice exercise to think what other factors go up there. And certainly surgeon acceptance and complexity of a system have to do with that, the value part, but there's also the patient in there. So, and the patient can come in like the functional outcome. Mm-hmm.
To complement Leo's answer, I would say this was what we were discussing last week, that from the very, very first moment, you have to think of ethic, in the sense that when you're designing your new automatic solution, at the same time, you have to think of semi-automatic, you have to think of giving control over, you have to think of nothing functioning, what would be the backup. So I think we have to think of all of it, and not only, oh, I want to do a cool robotic system and bring it in. I don't care what happened. So this is what your question comes. And I think this means taking ethic from the very, very first moment. And as you say, patient outcome, cost, even thinking of cost at the very beginning, and how can healthcare manage it to bring it to everyone, but also exactly what you're telling. How can, I reduce the risk? So I have to also be thinking of the backup, thinking of something not working at the very, very beginning. Because as we know, as engineers, sometimes you forget this. And then your system does not even allow you to go one step back or take over the control. So this is something we should, your comment is very valuable, and we should think of it at the very first, the way we are designing the system.
Okay, so thank you very much, both for the questions here and from the chat, and look forward to seeing you all in the presence in a not so long future. Thank you very much.
Thank you very much.